Okay, you're good.
Okay. All right. Rationale for intervention. Some background about Ebola. In the year 2014, it was discovered that samples of Lassa fever showed evidence of the Zaire strain of Ebola virus in Sierra Leone as early as the year 2006. Prior to this, Ebola had not been seen in Sierra Leone or even West Africa. It is said that fruit bats are natural carriers for this disease, which are native to Africa and Sierra Leone. Other types of meat that is native to West Africa were also known to carry the disease. Transmission of the disease is believed to be contact with the blood and body fluids of those infected with the virus, as well as handling by raw bushmeat such as bats and monkeys, which are important sources of protein in West Africa. Infectious body fluids include blood, sweat, semen, breast milk, saliva, tears, feces, urine, vaginal secretions, vomit, and diarrhea. Even after a successful recovery, the infection can stay in the body up to 12 months. In October 14th, it was suspected that disease could be spread from handling paper from someone who's infected, which made it even harder to keep adequate records in Ebola clinics. Sierra Leone also has really strong and very involved funeral practices. This includes rubbing the body with oil, dressing them, hugging, and kissing the body. This may have aided the transmission of Ebola because those that die from Ebola diseases are thought to have high concentrations of the virus in their body even after they died. Discussing outbreaks in Sierra Leone, it was one unsafe burial that ended up leading directly to Sierra Leone's explosion of Ebola cases in the summer. The country's first diagnosed case when a pregnant woman was admitted to a hospital in the Kinima district following a miscarriage on May 24th. She was infected and no one else had. Identifying the source of her infection, however, illustrates how the virus entered the country. The woman had attended the recent funeral of a well-known traditional healer. The healer had treated Ebola patients, flocking to seek her care across the border from Guinea's Guaquidou region before dying herself. Health teams working in the region identified further 13 women who caught the virus attending the same burial, starting a chain reaction of infections, deaths, and more funerals. According to the WHO, quick investigations by local health authorities suggest that participation in that funeral could be linked to as many as 365 Ebola deaths. From there, Ebola spread to Sierra Leone's capital, Freetown, where overcrowded living conditions and fluid population movements helped it to spiral out of control. A tragic footnote at the end of the study, produced by doctors and scientists tracing the outbreak into Sierra Leone, highlights the ultimate price some health workers have paid. 5 of the reporters' co-authors included Sierra Leone's leading physician spearheading the fight against hemorrhagic illnesses in West Africa, contracted Ebola and died before the report was published. Statistics and facts. Ebola hemorrhagic fever is a disease caused by one of 5 different Ebola viruses. 4 of the strains can cause severe illnesses in humans and animals. The first human outbreak occurred in 1976 in northern and southern Africa. The virus is named after the Ebola River, where the virus is first recognized. Ebola is extremely infectious but not contagious, but very small amounts can cause the illness. Laboratory results from primates suggest that even a single virus may be enough to trigger a fatal infection. People can be infected by coming in contact with body fluids or contaminated objects for someone who is infected. Researchers believe the most likely natural hosts of this disease are fruit bats. Symptoms of Ebola typically include weakness, fever, aches, diarrhea, vomiting, and stomach pain. Additional experiences include rash, red eyes, chest pain, throat soreness, difficulty breathing or swallowing, and bleeding, including internal. Typically, symptoms appear between 8 and 10 days after exposure to the virus, but the incubation period can span 2 to 21 days. Unprotected healthcare workers are susceptible to infection because of their close contact with patients during treatment. Ebola is not transmissible if someone is asymptomatic or once someone has recovered from it. However, the virus has been found in semen for up to 3 months. Deadly human Ebola outbreaks have been confirmed in the following countries: the DRC, Gabon, South Sudan, Ivory Coast, Uganda, Republic of the Congo, Guinea, and Liberia. According to the World Health Organization, there is no specific treatment or vaccine, and the fatality rate can be up to 90%. Patients are given supportive care, which includes providing fluids and electrolytes and food. Some highlights. Some facts: 2014 outbreak. Sierra Leone had 3,706 cases with 1,259 deaths. March 25th, 2014, the CDC issues its initial announcement on an outbreak in Guinea and reports of cases in Liberia and Sierra Leone. In Guinea, a total of 86 suspected cases, including 59 deaths. Its fatality ratio was 68.5, had been reported as of March 24th, 2014. Reasons there needs to be intervention. It's clear that through the statistics, this disease is sweeping the nation Africa, and Sierra Leone is one of the highest affected countries that Ebola is taking its toll on. It's imperative that action is brought to the country now. Not only does there need to be a vaccine created, but there needs to be a long-term solution that can better equip the people of Sierra Leone from future outbreaks of different diseases that can have the same toll as Ebola has and still is. We have come up with a solution called mHealth Outreach that will provide a solution and help prevent other massacres like this of Ebola.
So the mission of our organization, mHealth Outreach, is to provide international health workers with mobile technology embedded with tools that enable them to communicate during epidemics, maintain public health reporting, and boost training, diagnosis, and treatment in the developing world. So we have set several goals that will allow us to fulfill our mission statement in any international location that we implement our program. As we move forward in Sierra Leone, we will complete the following steps or objectives in order to fulfill the goals we have set in place. Our first goal is to provide international health workers with mobile technology that is embedded with the Medic mobile app. In order to obtain the funds to purchase smartphones for international health worker use, we have a plan in place to collect used phone donations. Our marketing strategy is mainly supported through our website and social media platforms. We will then use the funds obtained by the recycled phones and available government funds and grants to purchase smartphones that fit the needs of the developing health communities. These phones will have the Medic mobile app installed and ready to use. Our second goal is to train health workers how to effectively utilize the mobile health technology in the developing world. Our Sierra Leone program allows local doctors to have phones. We ensure that the local health workers will be trained on how to use smartphones to their full capabilities, including communication and internet usage. Instruction on the Medic mobile app features of health and training and tracking abilities will also be taught. Our third goal is to provide health workers with the technological support they need to maintain the effectiveness of their phones. Once we have fully trained health workers on how to use their smartphones and the Medic mobile app to their benefit, we will ensure that a member of our Sierra Leone team, who is a local native, is trained on how smartphone and Medic mobile maintenance works. We will offer continuous long-distance support from our core operations team. So by establishing our mobile technology intervention in Sierra Leone, local health workers will have the tools they need to reduce and eventually eradicate the Ebola epidemics in the surrounding region.
With all of the types of phones that we have in the world today, we were first left with a choice: smartphones versus flip. There are pros and cons to both, such as the flip phone does not have the internet capabilities that a smartphone does, and that way they could help these countries out. The problem with the smartphones is they are significantly more costly and would take more money to get down there. Our capabilities, such as the way a smartphone can browse the web for emergencies for people, would be very beneficial. I could go on about the smartphones and flip phones, compare about the choice that we felt as a group would be the smartphones, simply because of the explosion of the app world. We can seamlessly tie the world together through an app that people can share information through. We would download the medical app, Medic Mobile, that offers health workers to use Medic Mobile to register every pregnancy, keep stock of essential medicine, and communicate about emergencies. It offers doctors to upload information and send out messages with the app. It also allows the doctors to know what is going on around the area from others who have posted and sent information on the app. Information will constantly be spread throughout our different sites to our workers through the application. At this point, our workers can utilize radio or cellular to spread up-to-date information. How we will obtain these smartphones: we will create a website to educate the public about our cause. We will do these by putting ourselves on social media like Facebook and Twitter. We would advertise online and find people and organizations who are interested in donating old cell phones to help the people in Sierra Leone. We will allow people to organize a phone drive in their communities and in their workspaces. We would offer an option to donate money for phones and to help fund internet on this site as well. After we have received these phones, we would have them recycled by a company and that best meet our needs and take the profit from that and purchase new phones. We would like to pick phones that are rugged, simple, cheap, and have long battery life. From there, that is where we will download the Medic app on the phones to help the healthcare workers who would receive the phones from us. How we will help Sierra Leone find the cell phones: we will go to the government and they will fund the bill by the government that helps pay for the service, and then from the donations from the cell phones drives, that is how we feel our doctors and workers will be able to get the phones to help the healthcare in Sierra Leone.
Okay, we understand that we will face barriers as we introduce our plan and start implementing it. To help lessen these barriers, we plan on having a cultural specialist on our Sierra Leone team. This person will be a native Sierra Leonean who is well respected in the community. This person will be chosen because they understand our goal and are willing to be a spokesperson to help get the plan out to the doctors, IT specialists, communication specialists, and radio personnel. We will work with this person to send commercials out over the radio at the very start of our plan implementation to spread the word about the benefits of mobile technology. Another barrier will be that of limited internet access. Mobile cellular service is growing rapidly, but coverage still remains limited in Sierra Leone. 3G was recently introduced, so internet is on the increase. This will be to our benefit. Initially, we will give phones to doctors who are in areas with internet. Until more areas are equipped with internet, we can rely on radio to transmit messages and to use it to help other doctors get information they need to help their patients. As areas acquire internet, we can then equip and train doctors to use their new phones. So let's move on to implementation. Who gets a phone? After all of our research and hard work to advertise and get our idea out to the public and the collection of phones, the implementation of our plan will take place. We will send our core operation team of trained doctors and engineers to Sierra Leone to start the work. Doctors can earn a government-supported phone by teaching their patients preventative measures and to follow up on those frequently. The doctors will be allowed to use their phones for their own personal use. We want them to become very familiar with their phones and understand the capabilities of them. This will also make it much easier to get a hold of them if they are not at work when an outbreak of some sort occurs. We feel it would also help them to feel some sort of responsibility for their phone and will want to take better care of them. The phones will belong to the company, so we can get them returned to us if need be. Who will fix the phones? Our mHealth Outreach Organization Core Operations team will train a local Sierra Leone team how to use and fix the phones. The core team will be able to offer support from a distance when needed. Our Sierra Leone team will consist of people who have some mobile technology experience or who are willing to learn. They will also have their own phones to use for their own personal use. But, like the doctors, the phones will still belong to the company, so we can get them back if the need ever arises. The Sierra Leone team will start with at least one IT specialist to be responsible for understanding how the phones work, and will be able to train the doctors and then fix the phones should they break. Now on to our communication plan. As part of our Sierra Leone team, we will have a specialist who will be responsible for knowing the plan should an outbreak arise and then implement it. I'll take you through an example of this. A woman makes her way to a local doctor because she is not feeling well, and all of her tried and known ways to treat have not worked. The doctor quickly realizes the woman has Ebola. After the doctor quarantines the woman and makes sure she is receiving proper care, he sends a group text out to the group that has previously been set up by our communication specialist. All of the doctors in Sierra Leone with a phone will receive it so they can be aware and help in any way they can. The doctor then calls the radio station to have them send a message out to the public about what to watch for and what they can do to help stop the spread and keep themselves safe. They can then contact airports and make sure people are properly screened before they are allowed to travel. The doctor can then refer to the Medic mobile app to continue to treat the woman. He or she can then use the phone to ask for any help and supplies they may need. Again, here is our outbreak plan. So determine if there is an outbreak, quarantine the patient, give care to the patient, send a group text, call the radio station, get a message out to the public, use the Medic mobile app, and use the cell phone for further help. As you can see, having mobile technology in Sierra Leone will greatly help reduce the cases of Ebola and many other diseases. Doctors will gain new tools to better help their patients. Many people will be provided with jobs as they join our Sierra Leone team. Again, here's the team. We'll have doctors, an IT specialist, communication specialist, radio personnel, a cultural specialist, and then our core operations contact. Everyone will get a sense of satisfaction as they help a developing country help themselves.